Start. Good morning and welcome to Fast Tracking Scotland, our first session of today, test. Before I introduce you to Michael, who's going to be introducing the session, just a couple of housekeeping notes for you. We want you to engage, get involved in the session as much as possible. So there is the chat function or the Q&A function. We'll have plenty of time at the end of the session. If you have any questions, use the Q&A function. And if you want to share any thoughts during the session, then please do use the chat function and change the setting to all participants and attendees so that we can all see it. And just a note from our sponsors that have obviously made the Fast Tracking Scotland Summit happen, but they have not endorsed, supported, or paid any of the speakers nor shaped any of the content. And a particular thanks to Owen Mumford for sponsoring this test session. So I'm now delighted to hand over to Michael, who's going to give us an introduction about why testing is so important. Over to you, Michael.
Hi, thank you very much, Nathan, and welcome everyone who's joined us today. So, yes, I was diagnosed on July the 4th, 2016 by the use of a home test kit. Now, at the time when I was actually diagnosed, I was quite complicit against it, or arrogant, I would say, because it was a time that we were in where HIV seemed to be an issue for the older generation. It was no longer something that we were seen to be affected by. So when I done my HIV self-test, it was more of a kind of a blasé to say that I can pat myself in the back and everything's going to be okay. Little did I know just how life-changing it was going to be actually getting not just access to a self-testing kit, but actually carrying that test out by myself. And it was an express test. It wasn't that I had to wait for weeks for the results. I literally had 15 minutes or 15 milliseconds by the time that I had taken my test to get the results to come back and say it was HIV positive. Now, I'm not going to lie, it was one of the largest life-changing moments that I've ever come across or experienced. However, it was one of the most life-changing and life-saving moments as well, because carrying out that relatively simple test didn't only take me 15 minutes of my time, it's actually saving me years of my life, because I've actually been able to find out my own status, protecting myself by being able to go into medication, which thankfully I can say that is very a manageable and treatable condition now. One tablet a day keeps HIV at bay. But at the time when I did do it, I was very unaware of how much HIV was still affecting us in this day and age. And that has driven me on to try and drive the test for people. There shouldn't be any excuse for people not to know their own status in this day and age. And as I say, it is a simple, quick 15-minute test that you can actually take to go and find out your own status. And you can do that in your own private time, or you can go to a more clinical setting if needed to actually carry that test out. But it is so accessible and it's such an easy test to carry out that really I think we should be pushing it to get test, and everyone should access the tests as and when they feel that they need to carry one out. So yeah, certainly having the fast track cities for Scotland, I believe, is a massive push forward, not just for the generations who have already went through a lot of the turmoil, but also to stop further generations from contracting or passing on HIV. And hopefully we can live in a zero generation where we no longer see HIV diagnosis. On that point, I'll just pass it back to Nathan.
Thanks, Michael, for that introduction. I think it's really important to hear from people where they've used a different testing technology than maybe some were aware of existed. And I know we'll hear from Rachel about HIV Self-Test Scotland shortly, and from Dan and Callum coming up on different ways to get tested. Testing is critical to reaching zero new HIV transmissions. There's a new UK-wide calculation for the first 90. The number of people living with HIV that are diagnosed is now 94%. That means, if accurate, that we're closing the gap and diagnosing people that don't know they're living with HIV. But we know that there's much more work to be done, especially in some of our most marginalized communities. COVID-19 is likely to, if not certainly, reinforced health inequalities when accessing testing. And that's why testing has to be the #1 priority in our recovery from COVID, whether in sexual health services, in general practice, through community testing or online testing options. I had the privilege to chair the Short Life Working Group on HIV testing between 2017 and 2018. And the HIV Testing in Scotland report that was published by the group had quite a few recommendations. But there were important recommendations calling on NHS boards to meet existing testing guidelines, to increase opportunities and options for testing, to increase awareness and education among the public, and to improve workforce development. 2 years ago, the HIV Testing in Scotland report recommended a national self-sampling service and a free national self-testing service too. Last week, for World AIDS Day, the First Minister announced nearly £400,000 worth of investment in a national self-sampling service for HIV and STIs. Now, this is long overdue, but it won't be a silver bullet. And as I mentioned, we'll hear about the HIV Self-Test Scotland service that was launched in May shortly. The HIV Testing in Scotland report also formed part of the evidence which led to the HIV Commission in England making testing their #1 priority. They've followed the evidence and rightly recommended opt-out testing in healthcare, making HIV part of routine blood tests. Now, this is already recommended in high prevalence areas, such as the city of Glasgow or the city of Edinburgh, but it simply isn't happening to the extent that it needs to. Yesterday, we launched the results of the Public Attitudes to HIV survey that was conducted on behalf of HIV Scotland. 71% of people said they would be comfortable being offered a test by a GP. And this needs to be part of our testing landscape in Scotland to challenge stigma about testing, but also reach people who face numerous barriers in accessing sexual health services or traditional HIV testing services. Late diagnoses continue to be an issue that leads to poorer health outcomes and increased mortality. We need to ensure that on a national level, missed opportunities for testing are reflected in training and development. We need to ensure that if there's a missed opportunity for testing in a dermatology department in Aberdeen, that training is rolled out so the same doesn't happen in Forth Valley. And stigma is still the single biggest barrier to testing. When it comes to testing, stigma manifests itself in very different ways. Not wanting to be seen going into a sexual health service, knowing the receptionist in Inverness and not wanting to out yourself. The fear of a HIV diagnosis and being ostracized by your peers or your family. The fear of the unknown, the fear of a death sentence or being infectious. Alongside ensuring we have accessible testing options, we have to get the message out there. HIV has changed. It can't be transmitted through kissing. Effective treatment means you can become undetectable and therefore unable to transmit the virus through sex. And this information is vital to ensure everyone knows, and I mean everyone, the public, our communities, people living with HIV. We're not fulfilling our duty if we do not give people the information that can change their lives. U equals U is not just a fact, it's life-changing information for many. As we move closer and closer to eliminating HIV transmissions, testing will become more difficult to reach those whose needs aren't being met by testing services. And we need a variety of options. GP testing, sexual health services, self-sampling, self-testing, community pharmacies, outreach street teams, and community testing. And when we reach our shared goal of eliminating HIV transmissions, it can't be job done. We can't let HIV testing fall back and risk further outbreaks in our communities. We can't risk undoing all the work that we've done and are still to do. The evidence is clear that testing for HIV is cost effective. When it's done right, we can reduce health inequalities, reduce poor health outcomes, and reduce mortality. All of these things save the NHS money, but more importantly, improve the health of our society. So it's right that we work towards eliminating HIV transmissions, absolutely, because in doing so, we contribute to the elimination of HIV-related deaths, the elimination of stigma, and the improving the quality of life of people living with HIV. So without further ado, I'm going to hand over to Rachel, who's going to talk about HIV Self-Test Scotland. Thanks, Rachel.
Thanks, Nathan. Just sharing slides there. Okay, thanks to both Michael and Nathan for that fantastic introduction. I'm delighted to be here today speaking on behalf of Waverley Care and HIV Scotland about HIV Self-Test Scotland. Some of you who are listening to this talk today will be very aware of what HIV Self-Test Scotland is, others won't be. So I'm just going to spend a moment at the start just giving you an overview of exactly what the service is and what it does, and then talk you through the circumstances that it came about and what our plans are for the future with the service. Anyone who hasn't seen HIV Self-Test Scotland before, please feel free, and I would recommend after this talk, go away and have a look at the website, kind of familiarise yourself with it if it's something new to you. So HIV Self-Test Scotland came about really as a result of the COVID-19 pandemic. We were aware separately as organisations, I think, that there was going to be a significant reduction in testing and access and choice moving forward with the pandemic. We moved into a lockdown situation obviously really quickly, and it became clear, I think, at that point that whilst we may not have thought we would be still in the situation that we're in now, that it was certainly going to last longer than perhaps we'd initially thought in the beginning of March. So it was clear to us that with sexual health services needing to limit face-to-face contact or stopping completely, there were going to be significant issues in people accessing HIV testing in the months ahead. We spoke, and Nathan contacted me very early on in the lockdown and the pandemic to talk about, is there something that we could do more of as the third sector, given the pressures that the NHS were under, given the fact that staff were being redeployed and there were all sorts of other issues coming up for the NHS, was there something that we could do? And we felt as though, yeah, let's do something. It was going to be tricky. It was going to be something we were going to have to do quickly and with limited capacity and funding, but it felt like it was the right thing to do. So HIV Self-Test Scotland is a very, very easy to use self-testing service centred around our website, where people can go onto the website, order an HIV test to be sent to an address of their choice. The test is free. Or there is an option to make a small donation really towards the service to pay for the test, kind of in a way of, you know, if you can afford to pay for a test, it helps somebody out who maybe can't afford to in the longer term. So really simple system. And we were lucky. We had a small amount of funding to launch the service with. So Nathan had already had some conversations with Gilead about the potential of looking at some small term self-testing pilots. So we were able to look at starting the service off with that particular funding. And there was also an existing relationship in place with BioSure. So we were able to access those self-testing kits quite quickly and easily. The other thing about BioSure, which was really helpful, was that they were in a position to take on the packaging, delivery, all of those sorts of elements of the service, which was something that was very much needed given the limited capacity that we knew as organisations would be able to put into the service. We kind of brought our own skills into the mix as well. I think that was really helpful. We were able to bring our experiences of testing, our relationships with colleagues across the country, and come together as trusted partners to bring that service together. It felt like the right thing to do. And obviously, although this was a response to the pandemic initially, we were thinking about, well, what could the longer term options be for this type of service? Going back to kind of what Nathan said in his introduction, knowing that this is kind of something that we were looking for Scotland anyway, was this the opportunity to take it forward? So how did we make it happen? We made it happen very quickly. I look back at it now and I kind of think, wow, I don't really understand how we managed to do that, but we did it. And we did that, as I say, with that initial funding, with the self-test kits from BioSure, with the partnership and division of labour between HIV Scotland and ourselves. That was key. Neither one of us could have done it alone. So I think being able to bring in HIV Scotland, their experience, their knowledge of, and the work that they've done around shining a light on testing options in Scotland, and also bringing in Waverley Care's experience of actually delivering testing services, it felt like such a natural combination. And in terms of the division of labour in the service, HIV Scotland took on the administration of the service, the maintenance of the website, the relationship with BioSure, and Waverley Care came in bringing the support element to the service. So we provide support through the website to anyone accessing a test, through a live chat function where we can kind of talk people through various things that they might need to know about the test. And I'll mention a little bit more about that in just a second. We were clear from the beginning that we wanted HIV Self-Test Scotland to exist as a separate brand. I think whilst we wanted it to be very clear that ourselves and HIV Scotland were sitting behind it, there was so much else going on at that time around different messages that needed to go out about COVID to our stakeholders, to our service users, that it really felt as though those messages, we didn't want those to get lost within the kind of publicity of something new. So it made sense for that to sit just slightly separately. We were incredibly lucky and really grateful to get the support from our NHS colleagues across Scotland really early doors. We had some fantastic support, and I think that support really allowed us to design the service in a way that would meet the needs of the individuals we were wanting to reach across Scotland, but they would also take account of the increased pressure that the NHS were under and were going to continue to be under. So that was really important. And that support also took the form of funding pledges, and we received those from 9 health boards. And again, that happened really quickly, where the health boards themselves were keen to say, okay, we know that there's limited funding. We're really keen to kind of pledge our own funding to assist with getting tests out to the people who need them in our particular areas. So that was fantastic. That support from the NHS also allowed us to ensure that we had really robust processes and pathways in place for support and treatment. Again, taking into account that everything was different, and that we, again, didn't want to put extra pressure on the NHS, but we also wanted to make sure that anyone receiving a reactive result through the service was going to be able to access that face-to-face support as soon as possible, and that made sense for each of the health boards that we were working with. So the initial response, we had an absolutely phenomenal initial response to the service, to the point where I think kind of Nathan and I both sort of gasped a little bit at the end of that first month with, wow, okay, if this continues to the popularity that it is, wow. So we had over 800 tests that went out in that first month, which was just beyond kind of anything that we'd expected. But when you kind of step back, you realise that actually that took account of a significant lag in services already. You know, we launched in April, and, you know, already there'd been a good month or so where people hadn't been able to access testing. There were all sorts of issues. And just because COVID was going on didn't mean that other people's ordinary concerns around accessing testing for HIV were just going to fade away. They were obviously still there for people. So that particular early response was unusual. It did start to sort of settle down, which was helpful for us in managing the service, but still consistently really popular. So at the time of publishing our first evaluation, which I'll come on to in just a second, we've sent out over 3,500 tests to people across Scotland, which is a kind of phenomenal figure for a service that's 9 months old. So far, 8 people have received a reactive result through the service and have been supported into treatment and care in a way that fits for them. And I think that's really important when we talk about kind of choice and working with individuals about what works best for them. It's about having those conversations about how to be that bridge between the service and treatment and care options. The live chat services that I mentioned before, which are staffed by Waverley Care staff teams, have supported over 200 people through the website, and that can be, you know, really basic questions about how does the test work, how do I go about the ordering process, right the way through to I've got a reactive result, what now, to actually my result was negative, but I'm looking for some additional support. How can I get in touch with different agencies, particularly, you know, during the COVID situation? So that's been fantastic. We were really clear at the very beginning of this service that, you know, we hoped it would be something that would be a long-term option, but if it wasn't, if it was just something that existed during COVID, then what we needed to do was ensure we evaluated it really thoroughly so that we could kind of prove the case for future services. So we produced an evaluation report just towards the end of last month, which was looking at, I suppose, the service to date, the demographics, everything that had happened up to that point, but also a bit of a deep dive into some of the reasoning why people were accessing the service and some of the other additional information that we felt would be really useful to know in terms of planning the service in the future. So as well as all of the demographic information that we collected anyway, we had 849 people who had agreed to take part in future evaluations, and we had actual survey responses from 384 of those. And 168 of those were also willing to take part in a more in-depth follow-up interview. So the survey asked a range of questions. We were, you know, wanting to kind of get information around people's knowledge about PrEP and PrEP, a little bit around kind of sexual history, also interested in, you know, knowing if there was any injecting drug use history, their previous testing behaviours, had they tested before, what sorts of testing choices had they used, but also a bit of customer service information as well about how did the site itself feel, how did the service end-to-end feel. For those who had received a reactive result, did those linkages to care work? And I suppose overall, did it feel like an acceptable and feasible service for the people of Scotland going forward? So there's a lot in that report, and I didn't want to try and cover everything in it today because there's far too much, but I would really, really recommend anyone who hasn't seen the report to go away and download it from either the Waverley Care or the HIV Scotland website. It's there quite prominently on both sites, and there's some really interesting information in there, and kind of happy to take any questions at a later date if anyone wants to come back with anything once they've had a good look at the report. But some things that jumped out were, you know, the high levels of individuals who'd used this service that perhaps had never tested for HIV before. So maybe indicating that some of those barriers were starting to be broken down, or that we were reaching out to individuals in a different way. Everybody really, you know, right across the board, were really satisfied with the service. The vast majority would use it again, and they would recommend it to somebody else as well. And I think the overall message from the evaluation was really that having this type of system, this online ordering, this dedicated website, the postal delivery, all of those things felt like a really feasible and acceptable means of accessing testing in Scotland, which was really heartening to hear. So as with every evaluation, what's really helpful is that it gives us lessons to take away and have a think about for the future. And I think our experience of running this service over the months, as well as the evaluation, has highlighted areas that we'd like to go and dig a little bit deeper on. There's more that needs to be done, I think, about how we reach out the service to different populations. It's been incredibly popular with gay, bisexual and all men who have sex with men. But there are populations that perhaps haven't accessed it to the same level. So within Waverley Care at the moment, we're doing a little piece of work about kind of acceptable forms of testing for some of the African communities that we work with. And I think that'll tie in with some of those key populations that we still need to have a look at. We know that there are different levels of digital literacy across our communities and also digital access. And I think everything that's happened throughout COVID with the move towards digital services has highlighted that for all of us. And we need to realise that some services we don't want to exclude individuals for those reasons. So there's something to think about there. Through the evaluation, there was also a point around exploring alternative means of support. So at the moment we've got live chat, but there might be options to think about, you know, does it need to have a dedicated phone line? Do we need to think about maybe video chat, video support, those sorts of things? So that's something to look at. And I think overall, you know, those traditional barriers that Nathan was talking about and that Michael touched on about traditional barriers to testing, whatever they might be for whoever that might apply to, they will still exist post-COVID. So we need to be thinking again about how do we make testing accessible and how do we ensure that whatever we're looking at here today is part of a suite of options for people. And I guess one of the big things for us, and again, Nathan touched on this, is how do we attract long-term sustainable investment into this service? We've proven it works. We've proven it works at a really difficult time. How do we ensure that it exists going forward? So a few things there to think about, and obviously keen to pick up some of those things as we move forward into questions. Just to acknowledge the health boards who have been involved in funding the service, and also Gilead and ViiV who contributed some funding. And just to conclude by saying that, yeah, if anyone wants to ask us any more questions at any point after today, after you've looked at the report, then please don't hesitate to get in touch with either myself or Nathan to speak about the report and about the service in more detail. And that's really a whistle-stop tour of HIV Self-Test Scotland. Thanks very much.
Thanks, Rachel. I'll now hand over to Dan, who's going to give a presentation about sexual health services and how they've coped during COVID.
Hi everyone, and thanks to Nathan, the HIV Scotland team of Fast Track Cities for inviting me to speak, and thanks particularly for the two great talks I've had the privilege of listening to because of being in this session. Thanks to both of you. You know who I am from the introduction, but just to say I'm speaking in a personal capacity today rather than as formally representing any particular group. So I'm going to talk about how sexual health services addressed testing in lockdown. So where we were, how we started to recover, and then perhaps more importantly, where we are now, and most importantly, where do we go into the future? And I'll try not to overlap too much with what's already been said. This is unpublished data, but this is just an illustration of the way that HIV testing through sexual health services plummeted with lockdown, has recovered to about 600 tests a month, but remains lower than normal. And I'm only asking that anyone please don't tweet that in isolation. I'm very happy for people to see it in the context of this session, but I prefer it wasn't tweeted in isolation. So what happened with lockdown? Well, of course we know, but from a sexual health point of view, we stopped all walk-in services, pretty much every bit of outreach, and a lot of booked appointments, from everything from contraception to routine STI and HIV testing. And as well as that, importantly, outreach services for groups with various vulnerabilities, perhaps in the most noticeably people who inject drugs, was discontinued. I think it's worth mentioning at this point, however, that HIV testing in antenatal services and importantly in acute medical services From what we know so far, we've not got comprehensive data. It looks as if it was maintained and probably increased in acute services. And that was really important, and is important going forward, because we know that not large numbers, but some people who were presented with respiratory chest symptoms and were initially thought to have COVID, had HIV tests and were found to have late stage HIV. And so that was really important. So what did we do immediately? Well, you know, I can't give enough credit for the fact that THT maintained the services they had contracted for HIV testing to various health boards, and with a fabulous agility of the third sector and being unburdened by being part of the largest organisation on the planet, nearly, colleagues managed to set up HIV Test Scotland, has been discussed. However, to give the NHS credit, there was an absolutely unprecedented and incredible rapidity of response within all parts of the NHS in terms of consolidating, redirecting remaining services that hadn't been redeployed towards COVID risk, which, for example, involved redirecting outreach services to provide services for homeless individuals who'd been temporarily housed in B&B accommodation, and providing a range of services which included sexual health and HIV and Hep C testing to those populations. And that happened within weeks. We did maintain PrEP services, initially for urgent supply only, but even PrEP review appointments were starting to come back online by June, and PrEP starts were in place across Scotland by September. What persists and remains is we've still got limitations to accommodation, really quite significant ones. So a significant number of sexual health services don't have all their main accommodation, and nobody has all their local clinics. So, for example, in Lothian, we're running out of 3 instead of 11. So we are really significantly restricted. There was some limitation to laboratory capacity. That largely, not entirely, but largely affected testing for things like chlamydia and gonorrhea, which are actually in some cases run on the same machines as COVID tests. So you can clearly see a conflict in priority there. But there was some limitation to laboratory testing capacity, which continues. So in terms of rebuilding, what actually happened, perhaps one of the most positive things was a really rapid sharing of skills across sexual health and other teams. And I'm talking about things like harm reduction teams who are dealing with people who inject drugs and people with drugs and alcohol issues, to restart outreach. So teams that had previously used one technology, for example, dry blood spot testing, were very rapidly trained and supplied with point of care tests. Greater Glasgow and Clyde used an existing big commercial provider to maintain their testing for people on PrEP. That was an online self-sampling solution. In Lothian and in one other board, we very rapidly and on a very small scale developed and evaluated a self-sampling solution. And I could not overemphasize how cobbled together and frankly Mickey Mouse that was. The development of for example, the development of the patient information was my registrar taking photographs of me pricking my finger on her phone while I was in the middle of my HIV clinic so that we could put together the patient information. But that's gradually and been very well evaluated, and we're gradually building to build that capacity. And then on a national level, a number of us through the HIV leads and the SRH clinical leads developed this bid to support eHealth solutions for a more sustainable national solution. And as Nathan has very eloquently described, we've been successful with that. So going forward, we're working literally today on an SHBBV recovery plan, and there will be a full revised framework for SHBBV for Scotland from 2022. The Minister of Public Health announced, as Nathan mentioned, this relatively modest but incredibly important amount of cash to coordinate a national solution, which will support the IT to support it and a project manager to put together a solution for the future. So how does this relate to the central issue, the test? Well, clearly, my personal suggestion is we need an overall national testing solution that provides equity of access and proportionate universalism. And that means, I think, a multi-level framework. Part of that will be an online order self-sampling solution, or possibly a self-testing solution. And that's for high volume testing linking with sexual health. That's the 1,600, 2,000 tests a week. And that will include repeat testers. We definitely, and I think has been very eloquently illustrated by Rachel, need an online self-testing solution for anonymity. But at the same time, we've got to remain cognizant of the issues around digital exclusion. You know, that's where we've got what we've got to fix. So we've got to strengthen walk-in and drop-in testing in a whole range of settings, and we've got to widen those testing, those settings. As Nathan said, we need some work on reinforcing opt-out testing in GP, and of course there's been for years good work done in terms of prompts, but there's been very good recent work discussed about using GP IT systems to use prompts to identify those individuals who might benefit from a prompt to test. And we need to build on this increased consciousness within acute settings about testing people at potentially at a late stage of infection. And then for those groups with multiple vulnerabilities, including digital exclusion, and who also sometimes are groups with a higher prevalence of HIV infection, we need some really creative outreach solutions that might include point-of-care testing, which can be delivered by so many individuals, and potentially oral testing. And I think the notion of nationally coordinated remote support is a great idea. So a single point of support where people can, through video or phone links, can be supported through testing. And just to finish, to me, one of the major strengths and one of the major reasons I'm so enthusiastic about the fast track cities is this core issue of stigma. Nathan expresses it so much more eloquently than I can. Clearly, in the next framework, we need to readdress stigma in the population. But that may or may not be within our gift, but what I think is within our gift is to aim for zero stigma in health and social care. And I would really like us to make a commitment to zero stigma in health and social care. That's a big population, but it is doable. It's an achievable aim, and I'd really like to see us go for it. Thank you very much.
Thanks, Dan. Is now delighted to introduce Callum from the National AIDS Trust, who's going to talk about their work on community testing.
Hi, thanks so much, Nathan. I'm just going to try and get this PowerPoint set up. Hopefully that's working for you now. Yeah, so thanks very much for asking me today. Thanks to the previous speakers. My name's Callum, and I'm speaking on behalf of the National AIDS Trust. And I've been asked to speak today about the role of community-based testing due to, oh, I'm struggling with the slides, due to a piece of work that I led last year to develop two toolkits for NAT around community testing. One was an intervention design toolkit, and the other is an evaluation toolkit. And though these resources are sort of formally England facing, as they are funded by Public Health England, much of the information, sort of the guidance and the learnings within will be applicable to Scotland too. So what do we mean when we talk about community-based testing? It is testing that's led by community organisations, and is delivered typically outside of traditional healthcare settings, normally using point-of-care tests, although not exclusively. It is designed to engage specific populations and to be accessible and acceptable to those populations. And the main way of doing so, of ensuring that, is by ensuring that those populations are involved in the design and delivery of interventions. So in terms of where community testing sits in sort of testing policies, BEVA's new or latest 2020 HIV testing guidelines state that community testing increases testing rates in at-risk groups and should be provided or commissioned as part of local HIV testing programs. And then NICE sort of drills in a little bit further to say that community testing should be offered in areas with a high or extremely high prevalence of HIV, using venues such as pharmacies or voluntary sector premises, and in venues where there may be high risk sexual behavior, such as public sex environments, or where people at high risk may gather. Obviously, Beaver's testing guideline is not as specific in terms of where it should take place, which I imagine is a reflection or reflects the fact that even in areas that might have a low prevalence, you might have high prevalence amongst certain communities or high rates of late diagnosis. And these guidelines are supported by international guidance with both the World Health Organization and the European Centre for Disease Control recommending the expansion of community-based testing. Why then is it part of all of these different policies? Essentially, because it's part of a strategic whole systems approach. So as we've heard from other speakers today, it's important that all parts of the system are considered when we're designing local testing responses. And to reach all populations, it's recommended that testing is available in a range of both medical and non-medical settings. It can be more accessible and acceptable. So a recent systematic review of HIV testing in Europe concluded that community-based testing is an acceptable and effective strategy for reaching populations at higher risk of HIV and who may not be accessing testing elsewhere. It can be targeted, flexible, and innovative by virtue of the fact that it doesn't have to be a one-size-fits-all model, and I'll touch a little bit on some statistics around that in just a moment. It mobilizes existing community resources. So typically, those providers already deliver HIV testing as one service amongst others and have strong links with the local community that they are embedded in. And it enables effective health promotion, empowering people to manage their own sexual and wider health, reducing stigma, and normalizing HIV testing amongst key populations. It also provides a gateway not only into HIV treatment and care, but also to other services relevant to people's needs, such as drug and alcohol services or mental health support. So the data on community testing is limited compared to that of clinical settings. In England, the data from 2019 suggests that there were around 35,000 tests. Those were reported through PHE's voluntary survey. So we know that there's going to be more tests that were completed, but it is the case that they do represent sort of a fraction of the number of tests that take place in medical settings. That said, average reactivity rates based on the responses to that survey in community settings were 0.5%, which compares to 0.1% in sexual health services or 0.2% in specialist sexual health services. Of those clients seen in community settings, 52% were gay and bisexual men and 11% were Black African. So obviously those rates are significantly higher than seen in less targeted settings, and 37% of clients were first-time testers. Those last two statistics I think are notable also in that they are, in England at least, compared to the data from 2019 in online testing services, were both higher, which isn't to say that one's better than the other, but demonstrates that online testing and community testing, which are often kind of packaged together, do reach slightly different audiences. In Scotland, the data on community testing is not centrally collected, but THT and Waverley Care are the main providers. I'm not going to go into much detail as to the content of the toolkits today, because I think it'd be more valuable to talk about the impact of COVID-19 and the response that's been seen. But just to kind of briefly summarize, the intervention design toolkit looks at sort of the key factors to consider when designing interventions. So thinking about who to test, how to engage people, the staff, training and clinical governance that's required, the test itself and the process before and after the test. And the evaluation toolkit provides a guidance as to how services can be robustly evaluated and suggests a range of core and additional indicators that organizations or providers can use to do so. So in terms of the impact of COVID-19, obviously delivery of face-to-face services has become much more difficult, not just in community settings, but overall. Social distancing and PPE requirements have meant that it's not been feasible for many services to operate. And as a result, many community organizations have shut their doors and moved online. We have seen this has fluctuated over the course of the pandemic, and in summer we saw some resumption of services, and we're likely to be doing so again now. But ever-changing sets of restrictions make long-term planning really difficult for services. Why does this matter? Sex, as I'm sure you'll be shocked to know, did not suddenly stop with the arrival of COVID-19. We know that sexual activity also increased after the first lockdown, and I imagine that will be the case each time that restrictions ease. So the need for judgment-free, safe and accessible services is as high as ever. In terms of how services have adapted, I'd say there's kind of been two main ways that services have been able to continue to support testing. Remote assisted testing, so supporting clients online or via telephone to utilize the postal testing services that we've heard about today. This might be supported by outreach, including setting up or continuing existing sexual health advice lines, use of dating and hookup apps, and collaborative working online and offline. So for example, with faith communities, with homeless services, I'm sure that's been talked about at different sessions over the course of this conference, as some examples. And then some services have managed to maintain at times face-to-face testing with risk management and infection control processes in place to ensure safety. These have typically been run on an appointments only basis with high quality PPE in place. And a lot of the sort of discussions that would typically have happened as part of the face-to-face intervention have now been shifted to take place in advance, sort of over the telephone or online, with regards to pre-screening around both COVID and about sort of sexual history and sexual health advice. I realize I'm a bit short on time, so I'll try and kind of fly through this bit, but HIV Prevention England responded to this by developing a framework for delivering community-based HIV and sexual health services during COVID-19, with guidance on both of the two sort of main adaptations that I've just talked about. So in terms of assisted self-testing or self-sampling, their position is that organizations should deliver services remotely or digitally where possible. Platforms should comply with requirements around data protection and safeguarding, and all workers need to receive appropriate training and abide by the relevant principles of new or existing policies on clinical governance, infection control, and safeguarding. And face-to-face services should only resume when certain steps are in place. So when social distancing guidance can be followed, when steps such as around sort of infection control to reduce COVID-19 transmission have been applied, when premises have been risk assessed and made COVID secure, and when individual staff risk assessments have been done. They also recommend that point of care tests be replaced with assisted HIV self-tests to avoid personal contact. Risk assessment should be undertaken for any testing that does use point of care tests and will therefore require someone to be closer than 2 meters to someone. And the service will need to source appropriate PPE. Obviously, there have been challenges to this, and not all services who previously were delivering testing have managed to adapt to either of these different circumstances. Even for those who have, not everyone, and this is, I recognize something that's been talked about by others, not everyone has access to virtual services for reasons, for example, of digital exclusion, or they might not have the private space that is necessary to engage in those services and talk about something that is obviously private. People have concerns around confidentiality and sharing of personal data, as well as fears of judgment or recrimination for breaking restrictions around COVID-19. And we've seen some quite stigmatizing language around the messaging with regards to COVID. Obviously, physical outreach has been more difficult, and venues that previously shared spaces can no longer afford to share space, what with social distancing requirements of their own. and places that previously stocked or handed out physical materials might have are often not wanting to provide anything physical at this point in time. In terms of solutions and learnings, we've seen organizations develop infrastructure that's facilitated them to be able to continue to run in adaptive ways. So for example, of bespoke online booking systems, we've seen innovative means of outreach. So looking at two examples are installation of resource boxes at public sex hotspots and effective use of apps such as Instagram Live, although this has made capturing data more difficult because often people are participating in these type of platforms in an anonymous way. Non-HIV specific services have been more likely to resume face-to-face testing. HIV Prevention England are producing digitized versions of many of their outreach materials that can be shared with venues that might typically have leaflets or posters, and partnership working has been key in facilitating access. So just to sum up, community testing can support local testing efforts. It's not an either or with regards to kind of competing with other forms of testing, but rather it supports a testing strategy by reaching a particular group. And that COVID-19 has brought serious challenges, but the response has demonstrated the flexibility and innovation that is central to community-based testing. And moving forwards, community face-to-face testing will remain vital to end HIV transmissions, even as some organizations have adapted well to supporting online services. Thanks very much.
Thanks, Callum. Michael, do you want to come in and ask a couple of questions that have come into the panel? And if there's any other questions, then feel free to pop them in the Q&A.
Yeah, certainly. Sorry, can you hear me okay? Yep. Yep. So I'm just having a wee sort of a quick through there on the questions that have come through. It's great to see so many people getting involved for it. Now, one of the questions that I did see that popped up earlier on, it was about the testing that was done with yourselves through the start of the pandemic. And it was actually, so I'm just trying to find it again. They were asking what the number of people that had undertaken the test was and how many of those actually came back with a reactive result. And am I right in saying, Nathan, that it was over 3,000 tests that were done and 8 people come back with a reactive result?
So the way that the service works, and Rachel can add anything in if I miss something. Mm-hmm. So we've sent out, I think it's now about 3,800, 3,900 tests as of today. 8 reported reactive results. So we ask people to submit their results, but not everyone will have done. So out of I think about a third of people who have used the service have reported their results. And other people, you know, we provide a lot of information on the website, and this will be the same for all home testing, self-testing services. There's lots of information for people to self-refer into services. So they get a little card that says, I've used this test, that they can take to a sexual health clinic to get access to treatment if they don't do it through the service. But through the support service that's offered at HIV Self-Test Scotland, 8 people have been referred into treatment and care through Waverley Care's live chat service.
Perfect. So it is actually really great to see that there is such an uptake on the service still, given the current climate that we're actually having to sort of fight our way through as well. But taking us on from the actual testing itself, and it is a bit more of a personal experience with me as well, and I've saw it coming up on one or two of the questions, but it's more to do with the mental health and engagement with people who have either been diagnosed or affected by those living with HIV. And it's to ensure that we're getting the correct access for those who require it for us. I do believe HIV Scotland, Waverley Healthcare, and also Terence Higgins Trust have been working to the ends to ensure that they've still got the support they're necessary for the users that are actually requiring to still access the services, whether that is somebody who's been newly diagnosed or even a bit like myself. A few years ago I was diagnosed, but yet going through this episode, it still brings a lot of those issues back up. And what I was just going to sort of throw out there was a kind of a question back onto Waverley Healthcare to ask, what other services is it that you have got in place, and how easy is it for someone to actually access those? And what would you advise is the best route for access?
Thanks, Michael. That's a really good question. And I think you're right to highlight that the pandemic has just, thrown so much out of the water in terms of how people would traditionally access services. And I think also how people would traditionally hear about services. I think historically, we've always had such good relationships with our NHS clinical partners, and that has often been referral routes for individuals. They'll, have maybe that initial consultation, get all the details. That kind of makes a nice seamless referral through to ourselves or through to another provider in a different area of Scotland. And that's quite simple. And obviously so many of those pathways have broken down. So I think you're right. That key thing for me is how have we ensured that people who are perhaps newly diagnosed during that period still have access. And I think anyone who's kind of accessing testing through the HIV Self-Test Scotland website, that's where that live chat and sort of active dynamic support has been really important. You can get through to someone straight away on that website and talk about whatever you need to talk about immediately. I think some of the other things we've done have been, perhaps for people who, just, maybe been diagnosed for years, but just, like everyone, just finding this period really challenging and wanting to kind of touch base, or perhaps finding themselves needing support for the very first time. I think, again, what we've discovered is that digital options have been really fantastic in reaching out to people who've perhaps never accessed our services before, who've perhaps been looking for a different route through. So we launched live chat services on our Waverley Care website and on our SX service website at the very beginning. We had the Waverley Care one in place, but we launched the SX one at the very beginning of the pandemic, again, to just give someone another way to quite anonymously and quite, just tentatively testing the water of getting support. And I think what's great about that route is that people can get as little or as much support as they want. If they just want to ask a question, or if they just want to reach out on that particular day and just have a conversation with someone, then that's great. What we found with that live chat service is it doesn't remain digital. A number of people have come through on that service, reached out to a member of staff, and there's been follow-up phone calls, follow-up video calls, and that's been another route to bring someone into the service. So I think at the moment that's been a key way. And I think that what we'll see now as we move forward into January, that some more of those more traditional routes of accessing support start to become available as well. But I think what we won't lose now is the new routes that have been put in place. Yep. Because I think for me, and I think as you said, Michael, about ensuring that there's different ways for different people to access that support is vital. Mm-hmm. There can't be one size fits all. We need to, and I think there's been some great lessons from the pandemic about reaching out to people in different ways, that we maybe needed the push to do, I think. And, that's ourselves in the third sector. And I think also the NHS, I think we've all shown how agile we can be when we need to be, and come up with new solutions to those things. So the overall message is the support is still there. The support is always there. Come to our website, look at what's available. And also, workers have been out there reaching out to some of the most complex and vulnerable groups throughout the pandemic. So those who perhaps don't have the digital access, we're still linking in with other support service. We're still reaching out in other ways.
Excellent. And that is very powerful to know that as well, that given the pandemic that we're going through, it's still not actually stopping the essential resources and support that's actually there for people living with HIV. Just following on from the sort of mental health side of it and going back on it a little bit about testing, Nathan, you might be the best one maybe to answer this one. Is the HIV self-testing increased the access to the testing for those living in rural areas? Because we do know that living in the cities and populated areas, it's easy to access the services, but those in rural areas are the ones who are most isolated and the hardest to actually reach. And have we moved forward any during the pandemic? Have we managed to get an increase for access to those services for those in the rural areas?
Yeah, the HIV Self-Test Scotland evaluation actually outlines in Appendix B the distribution by proximity to a sexual health clinic. So we broke this down into different categories. So whether you were within 5 kilometres of a sexual health clinic, so obviously for most people in NHS Greater Glasgow and Clyde or NHS Lothian, which are the biggest users of the service, most people were within 5 kilometres of a sexual health service. But even when you then move to semi-urban locations, so within 10 kilometres, semi-rural locations within 25 kilometres, rural locations within out with 25 kilometres, and then remote locations out with 50 kilometres, we absolutely saw use of the service. So even just looking at the remote locations, so more than 50 kilometres away from a sexual health service, we saw a good number of people from the Borders, NHS Highland, NHS Shetland and NHS Tayside, and also NHS Western Isles accessing the service. And you can dig deeper into that data in the evaluation, but I think it's clear that this postal service allows for people in very remote or rural areas to access it.
And I think just to follow on from that, anecdotally, you know, I'm based up here in Inverness with our Highland service, and I think some of the conversations we've been having with people who've used the service, you know, again, you can dig into the evaluation, but as I say, anecdotally, people have been saying, you know, this is amazing. I haven't tested before because of anonymity, confidentiality, other issues. So to be able to just reach out and get a test into my own home without kind of any additional service face-to-face issues, then yeah, I think it'll be interesting to kind of continue to see how that develops, and I think post-COVID, whether that is still as relevant as we're seeing it during COVID. So yeah, some interesting stuff.
No, certainly from myself taking the HIV self-test kit, I genuinely wish they were about years and years ago, because it does take away that self-stigma, but also it takes away a lot of the fear of actually carrying out the HIV test that people kind of are trying to avoid. It's a prick of a finger, a prick, a suck and a poke, as they say. So getting at access and making sure that people out of the rural areas are more inclined to actually go and order the kits and be able to do it and find out their own status is a massive game changer. And hopefully will be again a drive to our zero generation down the line. Now, on that point, has there been any exercises done to compile or publish a list of any face-to-face sexual health HIV clinics currently open in Scotland? Or can you hear me okay? Yep.
I'm happy to speak to that if you want.
Yep, I was just about to say, I think Dan might be the best one to jump onto that, please.
Yeah, so the short answer is no, but to expand a little bit, it's great to see that there's a THT clinic running in Dundee. In terms of compiling things, the sexual and reproductive health lead clinicians, so the leads responsible for each board, met weekly from the start of COVID until September, which was phenomenal in terms of just sharing what we could do, sharing our recovery plans, coming up with ideas, sharing documentation so that we weren't duplicating stuff to try and open up services. And as part of that, we gave a weekly update onto what we're doing, but that wasn't published. That wasn't published formally. In terms of an overall review, that is partly what's underway in terms of the recovery plan, which, as I say, is being worked on at the moment. And that was commissioned by Scottish Government. But that's basically a summary of what restrictions there were and what we've done in terms of rebuilding all SHBBV services. And obviously, given the capacity restrictions, we don't want to do multiple things. In terms of I think it's true that there are very few drop-in asymptomatic face-to-face clinics, but that is slightly deceptive in terms of what services are delivering. So, for example, a lot of services are doing a lot of phone triage. And if people are identified as having particular vulnerabilities, they actually are seen face to face. But clearly that's not quite the same as walking in or having direct access, but it's slightly deceptive in terms of it might give the impression that there's less service there than there is. So for example, we recognise that access for young people is a massive issue. And certainly it surprised me because intuitively, we might think that young people will be the best adapted to digital services. And it's very clear that that is not the case. Young people under the age of 20 do not want, or a significant proportion really do not want to access services digitally and remotely. They want to walk in, and quite often they don't actually know the range of their needs until they see somebody. So although we're not able to routinely across Scotland offer drop-in young people's services, we are picking them up remotely and then arranging face-to-face and prioritising those groups. So that means to actually collate what the face-to-face was would be difficult. And I think the other and more optimistic thing is, as Nathan said, first vaccination was this morning. I am very optimistic that sexual health services are going to be working with a vaccinated workforce, or at least a part vaccinated workforce, next month. I mean, how incredible is that? We could be actually thinking about a vaccinated workforce next month. That's going to change things so quickly. So actually collating things now is so quickly going to be, I hope this doesn't sound like an excuse, but it's so quickly going to be historical. We're putting all our energies into, let's get it done. Yeah. Let's do stuff. And clearly we need to document things and take the learning, but all our energy is going into getting on with it.
And it sounds certainly as if that is what's happening. It's getting on with it and using this time to actually propel everything forward. It's excellent to hear everything that has been going on from a sort of a personal side of things to what's happening in the background, and how much work you are all putting in to ensure that testing and zero generation is within our hands. Now, again, just staying on the kind of a caption of numbers and figures and results, Nathan, you did mention earlier on about the tests that had been sent out and how many people had came back with a reactive test. But are there any public health bodies currently capturing the number of results and tests being done in the services in order to best calculate for the first 90?
I don't think that our evaluation will have gone into that yet. And that's only because most of the public health colleagues are working flat out on COVID-19. But we've deliberately set out to try and build the most robust data set that we could, so that can help fit into those conversations and that calculation. So it's probably not working right now, but I think it was interesting to see in Callum's presentation the way that Public Health England allow third sector bodies to feed in what tests are happening. So I think that that's something that we need to look at in Scotland, is seeing how do we get that official channel, and it's probably copying exactly what Public Health England are doing in the future.
Excellent. I see we're already sort of hitting great targets when it does come to the 90 mission, which is amazing to see. And hopefully going forward, we can collate all those results and get the numbers back in and kind of put the final nail on the coffin, as they would say, for it. Now this, I'm going to open up one just for everybody here that's on the panel for you. And it's to ask, where do you see the continued role of third sector and community involvement in breaking down the barriers to accessing the testing, which is going to be such a key drive to ensure the 90-90-90 targets are blown out of the window, really? And that's just a general question for really everybody. So what I'll do is I'll just kind of start off and do Dan, Callum and Rachel, and then back on to Nathan, if that's okay. Dan, if you want to take off.
Okay, I'll try and keep it brief. I think this ties in with what I was saying, which is addressing, I think addressing stigma within health and social care services is within our gift. And to broaden that out, what I would like to see is that anybody in a carer or caring role in the very broadest sense, so including community members, volunteers, third sector partners, and all of those employed in health and social care organisations have clarity about HIV knowledge at the appropriate level, but also that we have a route to this network of methods of testing, so that people have got, even if it's not absolutely at their fingertips, they've got access so that they can support the individual in front of them to the appropriate way of testing and the appropriate support. And whether that's the online self-testing, self-sampling solution for sexual health, whether it's going to a national self-testing solution, or whether more and more people are actually equipped with a facility where either they or somebody close to them can just do a point of care test supported. I think that's what I would like to see. And I'm very much a sort of very, very Luddite practical guy. And so I can only really think of things that I can see actually being done. And I can see that actually happening. I think that's within our gift. So it's a good thing to go for.
Excellent. Callum?
Yeah, I think it's in terms of the role of the community sector, is providing that reach into communities to provide sort of the gateway. Obviously, we're very lucky in the UK to have an excellent kind of clinical sexual health network, but we know that not everyone does test, or that not everyone accesses services as much as on sort of an equal footing or to the same degree. So I think it's that being able to adapt and meet communities where they are, and use that expertise to then bring people into the system, or to continue to engage with them where they are, if that's what suits people best. So I think it's providing that range of options, and we've seen sort of from what Rachel was talking about, the way that the last few months have shown how adaptive the community sector can be. So it might be, obviously I'm going to kind of big up the traditional community testing model, but I think they have a real role in adapting to different technologies and showing how we can use different methods to make sure that people are supported, whatever sort of their background or situation is.
Great. And Rachel?
Yeah, I think the key thing is that we don't just accept stigma. I think that there's a danger that we design services around stigma. And what I would like to see is us designing services that are right for the people that need them, and that we can take stigma out of the equation. So I think, coming back to what Dan said, that is within our gift. Yep. Let's remove that, so that whatever services we are providing for our communities, we're providing them because they're the right services for those communities, not to try and circumnavigate other things that are going on around people feeling stigmatized. So I think that's for me the key thing. Let's not accept it. Let's move forward, let's address it, and then let's design services in the right way.
Yep. I'm actually just going to jump on top of that one there, Rachel, and actually say thank you very much for saying that, because that is someone living with HIV. One of the biggest barriers to even just using services and things like that is not just the stigma perceived, but the self-stigma. And if we can begin by removing that stigma, then hopefully moving forward, it makes everything a lot more accessible, and wants everybody else to access it without having to carry that burden. Nathan, just bring it on to you to kind of wrap things back up and have your final little say.
Yeah, thanks, Michael. I don't think there's anything I can really add to what Rachel, Callum and Dan have said, or what I said earlier. I think that, a lot of people have always said to me that the target of ending stigma is aspirational and we don't know how to do it. I think Dan's right in saying there are certain things in our gift where we can take forward training and workforce development in healthcare and third sector organisations. There's wider work. We published that public attitude survey about HIV, the biggest single polling done in Scotland, specifically about HIV, with over 2,000 respondents. We know now what needs to be done in terms of education more widely. So we just have to get to it. And get to work, and hopefully that recovery plan and the new framework that will come beyond that will move us away from thinking about stigma as an aspirational target and actually one that we can work to. But I know we've ran over time. It was a really interesting conversation. Thank you, Michael, for chairing that Q&A. I think it was really helpful. But I think we'll wrap it up there. Just leaves me to thank our panelists, you, Michael, for your introduction and chairing that last bit of the session. Dan, Callum and Rachel, thank you very much. To everyone that's been attending, lots of people agreeing with lots of points from everyone in the chat. The session's been recorded, so it'll go up on replay. If you've only managed to catch the last bit, then you can watch back, and we'll be starting back in 15 minutes with our interactive workshop on designing the future of HIV services. So see you all there. Thank you, everyone, and goodbye.
Thank you, and have a good day, guys.